morning, everyone. Welcome to Grand Rounds. Next week is, because of the July 4th holiday, there won't be Grand Rounds. A few announcements before I introduce our speaker. We had a pretty good week, grant-wise. Atir Abbas got an NARSAD Young Investigator Award for a study of the role of prefrontal cortical interneurons in cognitive dysfunction and schizophrenia. Jill Betty received a $3 million R1 from NIDA for a study of neurobehavioral mechanisms of cannabis use disorder. Sandy Comer received a $1.2 million R01 from NIDA for medication development for opioid alcohol abuse. Martin Picard was named an Irving Scholar by the Irving Institute, which is an internal but prestigious award mechanism, and it's a 3-year award for salary support and research support. And during that time, you have the title of a Herbert Irving Professor of Psychiatry. And Jeremy Veenster Vanderweel received a 5-year R01 of $2.5 million from the NIMH for investigation of the excitatory neurotransmitter transporter. Is that what EAT3 is? In the OCD pathophysiology. Anything I have to mention regarding the residency? Just that the new residents are coming. Okay, be on the lookout. I'm really delighted to introduce our Grand Round speaker today, who it's taken far too long. Is this the first time you're giving Grand Rounds? It's taken far too long for us to get here, but I think will be the beginning of what I hope will be a beautiful friendship and collaboration between his department and ours, and that's Dr. George Hripcsak, who's the chair of the Department of Medical Informatics at Columbia. The work that his department focuses on is really like some other kind of cutting-edge disruptive disciplines like precision medicine, sort of at the forefront, and we need to get into it more. And not surprisingly, the strategic planning process has identified so-called big data and quantitative approaches to examining it and deriving what information can be used for understanding disease, treatment, et cetera, as a priority for us going forward, along with select others. So I think this is a good way to sort of prime the pump in terms of planting seeds, and everybody's thinking about what things might be done, and George is willing to entertain any questions or interested parties in terms of discussion thereafter. I should also mention that within the Strategic Planning Committee, the individual that's sort of, not sure how he got saddled with it, but who's sort of headed up the exploration of this area is Jonathan Javich. So again, if anybody has questions about how to get involved or explore it further, you can also query him. Dr. Hripcsak is a native New Yorker. He went to Haverford College. He then came to Columbia for his MD and also had received a master's in biostatistics in the School of Public Health. He's been on faculty here, and after doing his training in internal medicine, in which he's board certified, he focused on medical informatics and has risen to the level of chair of the department. I guess Ted Shortliff was previously, so under the tutelage of Ted Shortliff, one of the most eminent medical informaticians in the country, George rose to become chair and the Vivian Beaumont professor of medical informatics. He is, and I'm going to read this because I don't think I could paraphrase it, but George's current research focus is on the clinical information stored in electronic health records and on the development of next-generation health record systems. Using nonlinear time series analysis, machine learning, knowledge engineering, and natural language processing, he is developing the methods necessary to support clinical research and patient safety initiatives. He leads the Observational Health Data Sciences and Informatics Coordinating Center. This is an international network with 160 researchers and 600 million patient records. For his work in precision medicine, he serves as PI on Columbia's eMERGE grant and as a PI in Columbia's Regional Recruitment Center for the All of U's Precision Medicine program. He's co-chaired the Meaningful Use Work Group of the U.S. Department of Health and Human Services Office of the National Coordinator of Health Information Technology, which defines criteria by which healthcare providers collect incentives for using electronic health records. He also led the effort to create the Arden syntax, a language for representing health knowledge that has become a national standard. He was elected to the National Academy of Medicine. He's also the American College of Medical Informatics, and he's just an extraordinarily talented individual in a unique area that I'm delighted we're going to be able to hear today. So please join me in welcoming Dr. George Hripcsak.
All right, thank you, Jeff. And yes, Jonathan and I figured out that I've been here for 36 years, so I've now beat the third of a century mark. Please excuse, so I have this subacute, post-viral, hypersensitivity airways, otherwise known as the stupid cough, for the last 3 weeks, so I will be using this, and that will slow me down, because usually I go at a rate of about a slide per second, and so now I probably have to double the length of my talk. So we'll see. So I'm going to first talk about Odyssey. It's an international initiative to bring evidence to people and to doctors. Our goal is 1 billion patient records from around the world to generate evidence, and Columbia University is the coordinating center of this effort. Right now, those are our sites. We have about 180 researchers from around the world and 600 million patient records, which is about 1/10 of the world population, but it's the easy 1/10. I think the other 9/10 are harder than the first 1/10. But we're getting there slowly. Why do we need this? This diagram, this is all drugs, all side effects. This is the evidence in the literature. What you want to see is a red rectangle. For each of these dots, we increase the size by 10, which is an area of 100 times. Otherwise, these dots would disappear. So basically, if you're prescribing a drug, you want to know what effect it'll have. And the amount of evidence we have about what effects it has broadly is invisible on this graph. What we want to do is do this entire thing where it's a big red rectangle where everything we want to know is studied ahead of time. What Odyssey focuses on 3 different areas: clinical characterization, what can be known to be true by just counting things. I'll give you an example of that. Population level estimation, so that's causal inference. What causes what? Both in drugs and also just treatments and what other kinds of treatments, surgical, et cetera. And last is patient-level prediction. Is this treatment going to work in me specifically given my properties? So that's what Odyssey works on. It's an open science approach, so everything we do is immediately on the internet. People ask me, can I put the slides on the internet? I'm like, yes, because it's already been up there for the last year. Every detail of the work we do is published. So when we run a study, you can run the study because every single parameter that we use in those statistical packages is actually published along with the study. How it works, how can you get 600 million patients from around the world? Everyone keeps their database behind a firewall. They convert their database to this very special format that specifies every little detail about every bit of information. And then we circulate we distribute the query around the world, and people just return the answers. And that's how countries like, say, Germany, which has even stricter privacy laws than the US, can contribute. South Korea has much less severe privacy laws, and they can contribute. In Hong Kong, Japan, Australia, et cetera, all of those participating in the effort. This is the data model where we store everything, and we have 43 vocabularies from around the world that we draw from. Because remember, we're getting from all these different languages. We have to convert everyone's drugs, everyone's diagnoses, everyone's procedures, everything to a common standard so that we can run one query in common around the world. Then we have a set of tools that help people do the conversion. We have data validation routines. We have tools to help you do research, so screens that you go through, kind of like going through the visual version of SPSS or something where it kind of helps you design a study. This thing does the same thing on these data. And then we show you the results with tree maps and various kinds of graphs and everything. Now, Columbia has a database of 5 million patients sitting there that we've collected since 1979 for diagnoses, 1989 for clinical data like lab test results, radiology reports. And so what I did is I went to the IRB, the Columbia IRB, and said, can I get permission for everyone to use that database? And they said yes, because we de-identified the data. So 12,000 people use INYP per month. So it should be many of the people in this room have used, has anyone used INYP or know what it is? And it's inside of Crown, and it's inside of SCM, or you can go to it on the internet. And if you click on Explore, you'll get this screen. And if you agree to the terms, and you see this IRB protocol right here, AA07805, that is my IRB getting permission for the medical center to use this database for research. So if you do research on this database and you get a result and you publish it, when you go to the journal, they'll ask you for the IRB approval. What you do is you use that number, and unfortunately, I'm the PI on that. And then when you get to it, I won't go into detail in this lecture, but it goes through, you can, you look at the data sources. Here, we're looking at our database, a little bit more female than male. You can start to see our racial categories, et cetera. You define cohorts, and you define estimation. That's where you define research. It's a little bit of a hard user interface to use. It takes some practice, and you need some training to use it, so it's very sophisticated, but allows you to do real research, and you can actually, in this, do a study and publish it without ever touching anything else. Of course, you can always go through the usual routes to get to the database, but it's unusual that we've given everyone who uses clinical systems in the medical center direct access to all the information. Okay, so now I'm going to give you some examples of research we've done in Odyssey, not just at Columbia, the broader thing. One thing is today we carry out randomized trials without knowledge of what goes on in practice, and we predict in the future you should run an observational research trial. Observational means we're doing it on data that have already been collected. It just means a retrospective trial and not actively collected and curated with a randomized treatment like an RCT would be. But we think that you should run an experiment first on retrospective data before you get $20 million to run an RCT. Because, for example, if you're checking a new diabetes treatment, you want to know that you're comparing your new treatment to the right old treatment. What if you're comparing your new treatment to a previously unused treatment? Like, it may be the top recommended, but if no one uses it, there may be a reason. We should know what people are actually using in practice so we don't actually study something and show that one unused treatment should be replaced by another unused treatment. So we're looking at what drugs people take. If you look at the causal diagram of why a patient in clinician might pick a drug, guidelines is one reason, but there are many other things that come into it. So we decided to run a trial, our first big trial, as how are people treated on 3 chronic diseases: diabetes, type 2, hypertension, and depression are the 3 diseases we picked. And then we ran the study on the network. Anyone can run a study on this network. You have to join the collaborative, write the protocol, debug it, sell it to the group because it's all voluntary, and bring the results back. So in November 15th of 2014, we had the idea of doing this treatment pathways, and within 3 weeks, 7 databases out of 11 had returned their results. So in 3 weeks, we had a population of about 210 million in this study with all the results back. So it's fast turnaround. If you were to sit here and decide, I'd like to do a study on 200 million people, it would probably take you longer than 3 weeks. Here are the databases we use from South Korea, US, UK, Japan, and Hong Kong. I think I missed someone. Here's the definition of so here's how we did the treatment pathways. You had to be off any drugs for the disease for a year because we really wanted people new to treatment. This doesn't guarantee it, but that's our surrogate for it. Then you had to be on treatment for 3 years straight with no lapses. That was so that you didn't go to another medical center and get a different treatment that we missed. And you had to have the disease diagnosed somewhere in that 4-year period. We published the paper this summer in PNAS, which was nice. And here's a summary of the results in a starburst chart. So for type 2 diabetes, the first circle is the first drug they took, the second circle is the second drug, and so on around. And it goes out to 20, but on a diagram that summarizes it, only goes about 4. Otherwise, you don't have many patients who did it. So for diabetes, you can see metformin was used 3/4 of the time. So there's good agreement around the world on using metformin. And then after that, it becomes more random. with, that looks like gliclazide being next. Gliburide being, what is that? There's a better way to show it. Oh, it's gliclazide next, but that's because of England. Anyway, I'll show you that example in a second. You see there's less agreement once we go beyond the first drug. So now I'm going to show you, we had 11 databases, 12 databases in total, but 11 in the paper. So this should be 11. I just picked 3 databases, and these are the 3 diseases: diabetes, hypertension, depression. So the first thing you see is the US uses metformin, the UK uses metformin, and so does Japan and Hong Kong, and South Korea. So does South Korea and Hong Kong, but Japan is very different. So you see Japan has a much smaller use of metformin. So we thought maybe their formulary was different or the government didn't pay for it. There was some other artifactual reason. But it turns out that Japanese patients, unlike their neighbors in South Korea and Hong Kong, don't get insulin resistance nearly as often, and therefore metformin's not effective, and their doctors don't prescribe it. And if you look in the literature, I didn't find it in literature until someone pointed it out. There have been a couple of vague epidemiologic studies that pointed it out, but here we see it in action, that the doctors know it, and they tend not to prescribe metformin.
So, George, just to explain, metformin works by a different mechanism of action than the other oral hypoglycemics, and that's why?
Yeah, so metformin will act, if you have insulin resistance, it's trying to counteract that as opposed to increasing insulin production, which is another mechanism. So you can either produce more of it or become more sensitive to it. So if you have insulin resistance, I think, and I'm not a physiologist at this level, but I think you're going to try to make yourself more, combat the resistance. Hypertension, you see less agreement. Here's Columbia, Indiana, and the Medicare database, just picking 3 of the examples. We use a lot of first-line hydrochlorothiazide, which we think is a good thing. Use a cheap, safe drug as the first line, whereas other places will tend to go straight for lisinopril or something. And then in depression, you see the least agreement, where other than, a prior probability, it's kind of like spinning a wheel. And that makes sense because even within classes, there's more idiosyncratic reactions. And you could probably explain to me better why we see differences. In this one, this is Medicaid. This is GE is general practice, and Optum. This is EHRs in general practice, and this is basically also general practice based on claims data. Private payer. So this is private payer general practice. That's Medicaid. And this is general practice electronic health records, so it's a mixture of different groups. And you can look at those data, in more detail later on. An interesting thing is 25% of hypertension patients took a sequence of drugs that no one else in the database took. So that patient had a unique sequence. So no one else looked through 240 million, no one else had that sequence of drugs. 25% of patients. So we give very different treatments to every single patient that comes in the door. So it's very personalized, but not necessarily precise. We see that in general. This is over time, 1989 to 2009. This is agreement on giving one drug. It's increasing in general. This red line is just kind of showing you that everything's kind of increasing in all the diseases. And that's not necessarily going to be true because we do invent new drugs periodically. We don't take them off the market very much. But in general, we're coming up with similar, coming to some agreement. Academic medical centers look different than general practices. Some of this is sample size, but some of it is just difference in how medical centers treat patients. But
is that monotherapy, meaning one drug versus combination drugs?
What it means is that one means you took one drug and only one drug for 3 years straight. That's what that one means.
Have you done that in psychotropics with psychiatric indications?
Yep, that's another. I should have replaced that slide. Sorry, that would have been a better illustration. There's less agreement, but there's still an upward trend. It actually looks just like this, but lower against the axis. I can pull that up. I might be able to pull it up while I'm still here. Then last thing, one good news is that claims data and EHRs agreed with each other, the green and the red line, because one is prescriptions and the other is fulfillments. And so they weren't necessarily going to agree, but they did happen to agree. So I guess I've already described the conclusions, but the bottom line is for network research that it's feasible to encode the world's population in a single data model and do evidence against it, and the stakeholders were willing to share the results, that it actually worked. We got many countries and many groups within the US to share their results, put them together, and publish in that paper. The papers are starting to look so everyone's an author who gives data, so it ends up looking like a CERN, kind of like, so if physics, if you were doing particle physics and you see those long lists of authors, we're growing in that direction. So now go to a slightly different topic. This one is, so that was characterization, just saying what happens. Now we're going to say, like, why does it happen? In 1950, doctors with excellent training, vast experience, and strong motivation tailored their treatment to each child, practicing medicine as an art, the best possible. And 10% of children survived under that. In the next 60 years, we took a more scientific approach, and where we did clinical trials and slowly figured out what drugs work in pediatric cancer. Now we have an 80% cure rate. So we've gotten better. Epidemiology, observational research, today is like pediatric oncology in 1950. You decide to do a trial, you go out, you decide, I'm going to collect data these way, I'm going to clean the data myself, I'm going to have my PhD student, my postdoc do some stuff on it. We'll use SAS, use SPSS, should we do survival analysis? I don't know. How do you want to correct for it? Well, let's figure it out as we go. Which variable should we include? I like this one, I don't like that one. And we produce a study, send it to a journal. They maybe we see if it's positive or not. If it is, we send it to a journal. They decide to send it in. And bottom line, as you'll see, just remember that 10% rate. And Odyssey's idea is that we can do better than that. That bespoke studies that are done in this style are out, and we actually need to start doing science scientifically. So here we have an example of looking at oral bisphosphonates in esophageal cancer, one published in JAMA, one published in BMJ, a month apart, on the same database, CPRD. So the same database, a month apart, one says it causes it, one says it doesn't cause it. So that's the current state of the art in observational research. So what Odyssey is trying to take a scientific approach and look at, well, what happens? Database heterogeneity, parameter sensitivity, empirical performance. I'm going to go through some things, but basically we're trying to take a scientific approach to it. How do we solve it? Well, first admit that there's a problem, and Ioannidis from Stanford has been publishing on this for decades. But not really proposing many solutions, just saying what's wrong with it. So we're trying to come up with solutions for it. So let me show you the literature first. So here's a diagram. This is the effect size, hazard ratio, or odds ratio. So 1 means no effect, right? Okay. Now this side is the standard error. If I plot the effect size by the standard error of that effect size, what I'm going to find is this is where you have a statistically significant positive result, which for side effects means it's harmful. It causes a side effect. Here, it's statistically significant negative result, meaning it protects you from that side effect. And the purple is where it's not statistically significant. That means this line is a p-value of 0.05, okay? So that's just how to interpret the next figure. We read 12,000 papers automatically and parsed them and got 30,000 results and plotted them on the screen. And what you see here is the medical literature. So it turns out that 85% of published papers have a p-value less than 0.05, which means either we're very good at guessing things that happen to be statistically significant, or we have publication bias, among other things. We know it's not just that we're guessing well, because as you can see here along the 0.05 line, it's a sharp cutoff between right here and right next to it. So that has to be publication bias. We're not just guessing correctly. What it actually means is that when we publish something is true, like coffee causes cancer, there's like a 10% chance that it's true. So the positive predictive value of these things is like 10%, which is harkens back to that pediatric oncology thing I get. We don't know what to divide by. You see, we don't know what was here. We need to know all the negative studies that were carried out. And the other thing is, you notice that there's an enhancement here, like another, there's a line here, and then it's less over there. So what that is when, say, I get a p of 0.06, And I asked the postdoc, well, I think you forgot these 3 variables. And they put in the 3 variables, and it's still 0.055. Let's add a 4th variable. Now it's 0.045. Now you got it. I knew we needed that variable, and that's what goes off to the editor of the journal. So in other words, that's called p-value hacking, where you just change the parameters of the experiment until you get something just under 0.05 and send it in. So,
that's done not just for studies that may find a safety issue, but for efficacy too, right?
presumably, although these are safety studies that we plotted. So these drugs by side effects, not treatment effects. So individual biostatisticians and epidemiologists may do a good study, but in aggregate, the medical research system is basically a big data dredging machine. So now I'm going to show you what we're doing to counteract that. So we're going to take a paper from the literature that we think does happen to be one of the good ones. It's a paper by a guy named Lee, looking at a drug side effect. It happens to use the Taiwanese, that's who I forgot to mention, Taiwanese insurance claims database. And so it's looking at serotonin, norepinephrine, Hripcsak, SNRI. Is that right? SNRI? Yeah. Versus SSRIs, that's it, in producing strokes. So which SNRIs versus SNRIs producing strokes, and they found that there was no effect. So first thing we're going to do is just duplicate that study in an automated fashion. So how do we repeat the study without having, because we want to do 100,000 of these studies all at once. So I don't have a postdoc I can point to. I need to point to a computer. So what we do, remember, the big problem in retrospective research is confounding. How do you prove an effect despite confounding when you haven't done a randomization in a randomized clinical trial? And one of the top methods is propensity score stratification. And I can't go through a tutorial on it now because that's an hour talk in itself. But basically what it does is it balances the 2 groups. So they're equally likely to have taken either drug. And then you can compare them. But that's imperfect. So a second step, so a lot of people do propensity score stratification, and the FDA has now accepted that. But you have residual confounding even after you do that. So we go another step and do confidence interval calibration, where we adjust based on negative controls, and I'll show you that. I'll talk about that a little bit more in a second, so that you don't gain any information, but you account for the residual confounding. You don't correct it, but you account for it. So here's 2 drugs, and we're comparing them, who took them. And this is the preference score. This is based on the propensity score that you get out of it. The way to look at it is, the degree to which there's purple, that is the blue plus the red together, that's the degree to which the patients who took the 2 drugs that we're comparing in this retrospective database look similar. To the degree that the blue and the red are separate on opposite ends, that means the 2 groups weren't very similar. So if I just did a naive study on the 2 groups without doing any corrections, these 2 humps look very different. But if I do propensity score matching, it pulls them together so that in effect I'm comparing them on the purple. Or more specifically, here's a plot of it. So before I do the propensity score, actually we did stratification, not matching, but before we did this correction, people differed by a lot. So this is 60,000 variables, each one of them plotted, and how much do the 2 groups differ? This is like table 1 in a table that looks for average differences. And you see this is a difference of 0.4 of the standard deviation. But after we do that correction, we're less than 0.05. So that correction brings this thing, on this axis is after stratification, this is before. So it corrects the things to get rid of a lot of the confounding. Then, even after that, we still have problems. So we take a bunch of things and we say, well, aspirin probably doesn't cause ingrown nail. Just unlikely that it causes. They might be in an association, but it probably doesn't cause it. Find a whole host of studies where the drug really shouldn't cause the side effect as far as we know, and do the study on the same database using the same methods and see how many of those come out positive. And if too many come out positive, then shrink down, make the confidence interval bigger, make your p-values worse to account for that so that you calibrate your p-value to a correct number. And we do that with confidence intervals. So we do those 2 corrections. We repeat the Lee study doing that, and that's all automated. We just push a button and it does that study. We find roughly the same result, only the difference is than the Lee study, we've published every single parameter, every single thing we've done, and we have all these diagnostics, like this red and blue diagram and like this p-value calibration diagram that says how confident we are that we got it right. Then we say, well, let's pick 22 outcomes. And let's consider a lot more treatments in depression and compare them all pairwise on 4 databases. So we're going to do 24,000 studies now. So I'm going to push that button 24,000 times. And we get this answer. So now you see a cloud that looks very unlike the published literature where we have all those negative studies that normally get censored. 11% are positive, which means about 6% are true positives, and 5% are just the nature of a confidence interval, which means that my predictive value is no longer 10%, but around 60%. So if I tell you something's positive, I still may be wrong, but I get it right a lot more of the time. And you can measure that because you can see the denominator of all the negative studies.
George, I'm sorry to keep interrupting, but the parameter that you used to make your adjustment in confidence intervals and p-values was, a rare and implausible side effect, ingrown toenails to aspirin or something. And so you're using that as a indicator of some flaw in the study or some bias or some other factors that interfere with the true variance.
Mm-hmm. Exactly. So I'm not adding any information by doing this. I'm just saying that if 16% of my true negatives come out positive, I need to adjust my confidence interval so only 5% come out positive. Because that's the definition of confidence interval. Given the null hypothesis, 5% are positive. So that way I know I have proper confidence intervals. The propensity score matching, that actually is better because correcting it that way, I actually correct for it. I'm adding information in effect because that's a good thing to do. This second calibration thing, it's just a readjustment. It doesn't add any information. So I'm losing some positives when I do that. I realize that. Every one of those 24,000 points is a full study with all the parameters and all the diagnostics. There's another one. This is just looking at the different patients who take different therapies, and you'll notice that these, the blue and the red, barely overlap. And that's, I think, electroconvulsive therapy versus a drug. So you would expect that the kind of patient who would get electroconvulsive therapy versus the kind of patient who get a drug would look very different from each other and can't be compared retrospectively. So that's basically saying that propensity score matching won't work for those patients. So we can look at this and tell, are we doing a stupid study or not? I guess I said all that. Doing all these studies is not data dredging. The fact that you're doing a lot of studies on a database, data dredging is not about what you study, it's about what you throw away. Data dredging is the medical literature because we do a lot of studies out in the field and we only publish a tiny proportion of them that we like to publish. That's what data dredging is. But if you publish everything you tried, then you have the denominator and people can make their own judgment. You can correct for multiple hypotheses because you know how many times I ran hypotheses, whereas you couldn't do that in the literature because you don't know how many studies were done. And in fact, all those studies have already been done because the data has already been collected. We just haven't pushed the button that does the statistics. All the studies are implicit in the database. We might as well look at the results. And bespoke studies, that is the things that our people do, they say that, well, we can optimize the study. But when you optimize a study by hand, when you have 20 parameters, I guarantee you put one in that you shouldn't have, and you left one out that you shouldn't have. So we never get these studies perfect, and at least ours, we have a reproducible way of saying how we did it. And then in the next 5 minutes, I'm just going to show you, I'll take the 5 minutes. I'm going to show you some stuff about noise and bias in the database. So those studies are based on these retrospective databases, which include claims data and electronic health records. So when I teach the medical students, I ask them, what does PERLA mean? And they generally say pupils equal, round, reactive to light, and accommodation. And I say, I didn't ask you what it stood for, I asked you what it meant. And then they start laughing because they realize what I'm asking them, and that, if you see PERLA in the record, in a note, does that mean that if you were an ophthalmology researcher, you could say, oh, here's a patient whose pupils were reactive to light and accommodation in an equal way because PERLA is written in a note somewhere. No, PERLA just means I looked in that person's direction and they seemed to have eyes. So we did a study of how many people, and this is a patient, not one of our patients, this is a person with one eye, with a prosthetic eye. So I said, how many people with one eye are PERLA on physical exam? And we did okay. Only 2% of people with one eye are listed as PERLA, but another 8% are listed as PERLA on the left or PERLA on the right, in which case I understand what they mean, but you can't be equal on the left or equal on the right, so they're misusing the term. So the point is, what gets listed in the record, you can't take it literally, you have to interpret it. Also, a lot of our records don't have a lot. So here are two patients. This patient had a single data point in the record. You can't do it. So when someone says they have a database of 5 million patients like ours, you want to see how many patients can actually do research on, because some of them are like a single CBC. Like I can't get any trends or anything out of it. So they probably have like 1/10 of that in useful records that you can do research on. That's true for us too. This was from a real paragraph, 36-year-old man, 27-year-old woman. And then what happened after that? Every note after that said the same thing, right? So because it gets, and not only that, but the good news is that we have eternal youth, because once you come to the medical center, your age stays the same forever in all the notes because they copied it forward. I was a 56-year-old woman for a while. Truly, I did. And it's complex, so this is like the notes now look like people are texting. So it's hard to interpret. But natural language processing, this is a paper from 1995. We're 20 years into being able to use computers to read these things, and they do pretty well. This is perfect, this is an ROC curve, so perfect performance here. Here are internists and radiologists. Here's our system. Here's laypersons, and here's a Google kind of search. So these sophisticated computer programs are in the pack of doctors able to interpret things. So we do have some good news here. But we have a lot of bias. So what tests you get are influenced by what's written in your record, which is influenced by your care team. So it's a big feed-forward network. Here's a study I did repeating Fine's 1990 approximately study on community-acquired pneumonia, and should you come in for IV antibiotics or can you get oral antibiotics? So I used the EHR, electronic health record, to repeat his study. And the odd thing is that the healthiest people die more often than the second healthiest people, which seems odd. Why would you want to be a little sicker to save your life? And the reason is, if you're really sick and come to the ED and die, no one records your symptoms in the record. So you look in the record as if you're healthy because what's in there is nothing wrong, and then you're dead. But what happened is you came in with a lot of symptoms and died too quickly for the doctor to write your note, and they didn't bother writing a lot of symptoms since you were already dead. That was one of several problems. There's IV drug abuse, so there's a couple things can go wrong. But the good news is that clinicians use the record for patient care. They know that PERLA doesn't mean PERLA. And so how can we deconvolve the truth? And so coming to a close soon, I'll just show you a couple examples. So we did something that we just for fun call the physics of the medical record, because we studied the health record as a natural object. Instead of studying the patient, we study the electronic health record. We build models and aggregate and test models, and we borrow from physics from nonlinear time series. This is just mutual information, but we do sophisticated methods. So one experiment we're doing is, controlling for healthcare process effects. So if you look at, creatinine, so kidney function, or glucose, a couple other things, blood count, anemia, patients at 3 in the morning get very sick, and then they're better at 9 a.m. until like 6 p.m., and then they start getting sick again, then they're better at 9 a.m. So why is that happening? Because if you take a naive view, who do you measure at 3 a.m.? You only measure their glucose at 3 a.m. if you're worried about their glucose. So on average, glucoses are going to be worse at 3 a.m. and creatinines and everything. So you need to deconvolve the truth out, so you have to do a proper study. So this is Granger causality or vector autoregression, where you try to factor out the effect. And I'll just show you one example of that. Here is simvastatin, so a cholesterol drug, and rhabdomyolysis measured by CPK. And what this says is when you start simvastatin, if you take a naive view, simvastatin is protective of your muscles, the opposite of what we think. It doesn't cause rhabdomyolysis, it protects you from it. Why? Because you come into the emergency room, we find out that you're on simvastatin. You've been on simvastatin for 10 years because your outside doctor gave it, but we know it when you came to the emergency room. What else happens in the emergency room? You came in for an injury. You have a high CPK. In 3 days, your CPK gets better because your injury is getting better. So it looks like you started on simvastatin and your CPK got better. If we factor out the admissions and things like that, we get a proper thing. Here's where the CPK goes up. So if you start on simvastatin, several months later, you may get rhabdomyolysis. But the day you start on simvastatin, you don't seem to have a lot of rhabdomyolysis. Why? Because doctors don't give you chronic medications when you're sick. They give it to you when you're healthy. So we can kind of tease out those effects. And last slide, and then the last one, we're looking at things like glucose metabolism. And we're starting to use mechanistic models. So what we're trying to do is say, what's your glucose? So this is a type 2 diabetes person, and they don't have a continuous glucose monitor normally. They do finger sticks. So these are their finger stick glucoses over the course of a couple days. And this is self-reported meals, how many calories they think they got, more or less. So that's the data set. What we want to do is predict when your glucose is going to be high based on the meal, or based on a meal you're about to eat, tell you what effect it's going to have on you, to see if you want to modify it. So we did something. We took a glucose model that is a mechanistic model. It says insulin and glucose and kidney function and liver function. And we paired that with data assimilation, which is a technique that matches it to the data. It's the way we do weather forecasting today, which has gotten a lot better than 20 years ago. And when we do that, we get these predictions, which over here, it's not that impressive because it's just kind of staying around the mean. But it does seem to guess this one, but we seem to miss that one. So it seems to do okay, and maybe that's a good sign, but somehow we missed that one. So we're suspicious. So then we say, our system that produced these red things, what is it thinking? Don't tell me just when the glucose was done. Tell me what it's thinking, and I get this. And when a machine learning person looks at this, they say, okay, this is crazy. This thing is just coming up with stupid things of glucoses to match the data. I'm overfitting the data. I'm overtraining is obviously what's happening. And that's what I said to our physicist. He counted with, no, people get these big spikes in glucose. It's normal. I say, well, show me the paper. I never heard that. He said, oh, no one ever publishes that, but everyone knows it. So then we put a continuous glucose monitor on someone. We hid it from the system, and this is actually this patient. That's what the patient's really doing. They get these stupid glucose spikes. Our system is detecting, is matching those spikes. You see this one we got wrong? We were just off by like 7 minutes. The spike was about to happen. They probably put in their meal time like 7 minutes ahead of time. That's how we missed the spike. We're doing like perfect prediction with this thing. If I gave a regular machine learning system this data, it would never figure out that it's supposed to look like this. You know what I mean? So pairing mechanistic knowledge with the data, putting together data science, big data, which is the current fad, with our mechanistic knowledge together, we can do much better predictions. So in summary, last slide, current observational research that's published in the literature is suspect. Large-scale observational research appears to be possible and appears so far to be more reliable than these bespoke studies that we do. But there's a lot of research to follow. And just to remind you that there's a 5 million patient database sitting in INYP if you want to do any research on it. So it'll be hard to use. I should have figured out, I forgot to ask who the psychiatry department's data navigator is. Who's the person who should help you. That person doesn't yet know how to use that system, but we're happy to train that person to use the system, and they can then train you guys to use the system. But it's going to take some training. It is hard to use, but now that I know how to use it, I can actually, someone asks me a question, I just log in and answer the question. It's amazing. Anyway, and I'll stop there.
George, thanks for really a whirlwind introduction to this area. Let me just ask two questions that are, I think, closely related. I mean, first, sophisticated and highly, sort of method-driven this approach is. It's really reflective of the old adage, garbage in, garbage out. In other words, it's only as good as the quality of the information that you have access to, as many as the cases may be. And, your efforts to try and deconvolute it or to systematically constrain biases and so forth is an effort to try and limit it. But it seems like it really requires sort of two efforts. One is to figure out, how do you mine these data for useful information, and the second is how do you improve the quality of the information. So let me just ask that first, and then see if that's consistent with your understanding, and then I'll ask the other part of it.
So it's always better to improve the quality of information going in. And, the nation is slowly working on that, and it was doing it with meaningful use, which the first stage one, I think, was good and a positive leap forward as we agree on terminologies. A lot of the reason we have bad information is based on our health insurance policies, and that doctors used to document clinical care for doctors to read or for themselves to read, and now they document for payment. And as soon as you document for payment, the incentives change and you do stupid things. And we have to try to then undo that information. I think that's the single biggest problem. Also, some liability avoidance, which is why they're cutting and pasting the entire CT scan report in their daily progress note when it's sitting right there, but they just want to show that they looked at it. So there's a bunch of stuff that really obfuscates the information, and it's getting so big, these notes, that even doctors are having trouble, even with their intelligence, reading them, never mind us using it for research. So the biggest thing we could do to improve the quality of data is not bill based on it. Whether we can accomplish that or not is a different question. If we, otherwise, but the nation's working on, artificial intelligence systems may help us do better documentation. I know of systems that as you're writing the note, it reads the note and say, you didn't comment. You're saying they're having a stroke, but you didn't comment on these 3 parameters related to a stroke, and things like that to make it more complete. We'll see. Someone has to want to do it. Someone has to get paid for better data in order for this to happen, though. And then otherwise, everything we do is post hoc.
So the other part is, as this is happening in the academic sector or in the health services policy sector, you've got the private sector like the Googles and the Apples and the Microsofts and Alphabets and so forth, going off trying to acquire data in sort of some systematic, comprehensive way that would yield these to the purposes of such kinds of analyses, whether it's passive monitoring or continuous glucose or blood pressure or cardiovascular. So, but it's happening kind of independent of academia, independent of the FDA, independent of sort of the scientific evaluative and regulatory process, which if it's ever going to be usable other than recreational information like 23andMe is for genetics, that's got to, there has to be some kind of integration. What's your feeling about that?
Well, we do have some links to Microsoft research and Google research. I mean, there have been some big missteps in Google with flu trends, of course, and that didn't go well, and also their work in the UK database without telling anyone they were doing research and things like that. And I think 23andMe is a perfect example of, as you, I guess you call it recreational, where, they're driven by advertising spikes. If you have a company driven by advertising spikes doing medical research, I mean, their incentive is hits on the internet, and so the current news programs, being a news versus politics, and then this is a parallel to Google doing health versus academic medical centers doing health. I think the FDA is looking closely, trying to increase their involvement, right? And that's why they reached out at 23andMe to try to pull them a little bit, rein them in on the claims they were making. Our faculty do communicate with faculty members on the other side. I mean, to the extent that they do something that IBM Research used to do, where they actually do legitimate research, which is independent of the company, and produce top results that are very important for the rest of the field, then they're treated as academics. And I think it goes better then, and there's a lot of collaboration. We get yelled at Columbia for being too proprietary. Here's IBM making everything open source. How come Columbia's IP office won't let us put this on the internet? Versus Google Research, which won't share one shred of what they're doing. So it depends on the company also. So I don't have an answer, but we have, in some cases, we're making inroads, we're collaborating very closely. In other cases, it's just a wall there.
Harold?
So, George, great presentation. So how does psychiatry get into the mainstream of this? I see that there's at least two barriers, probably many more. I mean, in addition to the fact that we don't have people trained in informatics and that kind of stuff, which is another question about how we can actually link to some of your training programs. But as I think about it, one is that we don't have lab tests. And while we do have lots of different ways of measuring things, it's not instantiated in LOINC and other kinds of things. That's number one. Number two is many of the concepts that we have are not in a standard terminology. They may be used by different people in different ways. They're not necessarily fully operationalized. You have some thoughts about how the field of psychiatry, mental health can move towards the mainstream of the kind of stuff that you've been doing?
Well, lately there's a lot of work in mobile computing on measuring how people's affect based on their behavior on their phone, which is becoming more and more of the population that it can, and they've shown, right? I mean, you guys know better than me whether it's been successful measuring the degree of depression with clicks and how they use the phone, or even what they say both on what they do, like clicking and stuff, or how much they use the phone or how many hours, and what they say on social media also has been measured, and what kind of words they use. So we may be getting a point where we do have some quantifiable stuff coming in now on the vocabulary in DSM-3 and DSM. I mean, you need to have a common vocabulary to get anywhere.
Yeah, well, not just on diagnoses, but also in terms of the kind of interventions that are done.
Oh, right. Yeah, so you need to come together as a community. I mean, I agree, you do need a common vocabulary to get anywhere. And need to map it to something, even if you map it locally. And then, what we do in Odyssey is every country has a different vocabulary. So we first map within the country and then map together across countries. I don't know if in this field of psychiatry there's an analogy there where you could make some progress within subfields and then bring it together afterwards. But you need to do something to pull together. Yeah, you mean different non-medicine-based treatments, yeah.
I think that the limitations in psychiatry, Harold's alluding to, sort of limit the application of such approaches. So, for example, we can apply this approach to treatment practices and treatment trends and so forth, but it's more difficult when we're looking at some type of indices of pathophysiology or symptomatology. The approaches that some of the private companies have been taking is that we're going to gather a lot of data and hope that they're somehow valid in reflecting some aspect of the illness, but there's no guarantees.
I just read a paper this morning on deep learning of images, and they produced, I can't bring it up fast enough, produced a set of images that the system was 99.99% sure it was a penguin, and it was like an abstract set of lines and circles. So it was very good at separating penguins in its data set, and it learned some property of penguinness, but nothing like what human beings would think of as penguinness. And when you could fool it by like drawing, I don't know, it was like an orange dot and a circle over there and a couple of black lines over there, and it said 99% sure it was a penguin. They did it for every kind of object. Electric guitar was something else, and some of them were just like static. It looked to human eye like static, and it said penguin, 99.99% sure. It was literally static. If you looked at the thing, you can't distinguish it. And so the danger in these companies take these large data and learn this stuff. It might work on their test set and on their press release, but you have to be careful that you're not the the human being patient being subject to it is not the the static on the screen or the lines and circles.
Well, just to illustrate what you were saying, can you just talk about, in diabetology, diabetes management, the idea of tight glucose regulation has become like a goal in terms of standard of care. So how does your data inform the validity or usefulness of that or not?
Well, the last thing we're showing, we're actually trying to use to improve. So what they did was, right, they showed that tight control in the ICU, say, improves your mortality and morbidity. Then they let it live, and people were dying from it because they weren't able to be as careful in avoiding hypoglycemia, and so they backed off from it. But if we could have a predictor that does a good job of saying what your glucose is about to be, maybe we can be tighter without creating hypoglycemia. So maybe we can create predictive tools that are better at adjusting the glucose. And if you look at how insulin is given in the, say, for non-diabetic patients who behave diabetic, like, in the ICU circumstances, our treatment for that is like this piece of paper with like rows and columns and what to do under different circumstances. It just, not only is it not personalized, it's not even that good even for the average patient, never mind the specific patient sitting there. So we can do better than that. So we're using the predictive model. So that last part I showed, I think, is the most useful there.
I'm looking at Melanie, who doesn't have her hand up, but asking her to put her hand up. And
as the person that you were referring to at the end, I'm the director of biostatistics in psychiatry, so I'm expecting a lot of phone calls after your presentation. I actually did have a question for you. I think probably many of my colleagues were wowed by your presentation where you showed we can do all these studies all at the exact same time with this one nice big database, and here, look at all the dots. Unfortunately, none of them are significant compared to what's in the published literature of the presentation. I wondered if you could talk a bit more about what goes into each one of those dots, and that in terms of, to the latter part of your talk, where you were talking about the problems in the data, that each one of those dots must have included some kind of inclusion criteria to decide that people were actually going to be compared, and that there needs to be a lot of work done to decide sort of what comparisons can be made, because maybe there's a lot of comparisons there that nobody would even necessarily care about looking at. And so sort of just basically a little bit more about what it was we were seeing when we were seeing 10,000 studies. What is in each one of those?
Okay, so each study, what we do is we're comparing two drugs on do they produce a side effect more or less than the other. We're doing a cohort design, survival analysis, Cox survival analysis. To match the patients, we're doing propensity score stratification going into it. We do it on all pairs, even those that can't be compared, but we show you the diagnostics so you know that this is a stupid comparison. So we give you so we could do them all. The way we select variables, we don't do, the way we select variables for the propensity score adjustment is lasso regression. So we literally do 60,000 variables into the lasso and let it pick. And we've compared that to the FDA's univariate predictive value followed by lasso, and we compared it to people manually picking 20 variables, and we find that ours is the most reliable. Just pick all 60,000, go through lasso, do the propensity score. And then I think we do some of the major covariates like age and gender and things like that in the final survival model, but we don't pick a lot of other ones. We let the propensity score matching take care of that. And then that's how we produce that result. And then we do the p-value calibration at the end. So we show that for all of them. So all those, but we show you the diagnostics so that you can see, oh, based on that thing, I don't think I would trust this result.
Well, or even care about the comparison. I guess that's what I was getting at. It's like, in order to be a dot, a person had to get that drug. And there might not be many people who got some of those drugs, and maybe we wouldn't care about comparing that to something else. And so that just to remind everybody that we're only be able to test things that are actually in the data.
That's
right.
One
of the main points I want to get across.
Okay, well, that's a good point.
And so we might want to do certain kinds of comparisons, but if there's so few people even getting that who are in your data with reliable cohort information, that is, they don't just have one observation, we're not going to be able to make that particular comparison.
And that's right, I forgot to say that. This is not all by all. This is just the ones that had sufficient sample size that we could do the comparison, so that is right. So we do have a lower limit in effect on that. But we don't know, someone may never ask, will I get more side effect with metformin or aspirin? Well, why do I ever ask that question? And so, but there's no harm in doing the comparison as long as there's sufficient data to support it.
I also just want to say it was a great talk. It was terrific.
Let me ask follow up on what. So how does this differ? Let's say, I mean, I know it does, but from let's say what the Cochrane group does, the Cochrane database.
Well, Cochrane they don't do studies, right? They look at studies and decide what level evidence they are, that kind of thing. Do I have that wrong? I think. So they're taking they're looking at the first slide, the thing with the big censoring, the V-shaped censoring, and trying to make sense of that and do a better job. So you could argue what they're trying to do is fix the V-shaped thing. What we're doing is just recalculating the V-shaped thing without the V-shape.
And meta-analyses do essentially the same kind of thing, using a meta-analytic statistical approach.
Yeah, to
Where they attach
achieve the
weighting
same
to
thing in the end, which is reliable evidence.
Right, but they're not doing the deconvoluting and the estimation of bias and the other
So the
things.
last, but I didn't do it either. So the last part of my talk to deconvolve the thing is not being used in the first part. The first part is taking it at face value. The propensity score matching is taking care of some of it. Also, the way you design the trial, you try to do it in a way that minimizes the kind of stupid things that go wrong. Sometimes we do self-controlled. I can't do it here because I don't have the same patient on two different drugs, very rarely, but on the two drugs I'm interested in. But if I'm looking at one drug and to the degree to which it causes a side effect, I might do a self-controlled case series or something. So the patient's on the drug, off the drug, and do they get side effects more when they're on the drug than off the drug? And that way they're their own control. So you can start, fixing some of the problems.
You looked at stroke in relation to SNRIs or SSRIs. The other interesting thing, if you haven't done, you should do is sudden death with antipsychotics in elderly.
We could do that.
That's
So that's why we got to get,
Yeah. Ralph?
One of the problems in these international things you're comparing, particularly in psychiatry, the reporting is so extraordinarily variable, particularly in terms of side effects. Now, I'll mention one simple thing, but I think you're light years ahead of us in terms of this kind of data for us. Let's say they have a new tricyclic in England, which was reported from Glasgow. And they presented at some big meeting how the incidence, let's say, of sexual side effects was like 1 or 2%. So I said, how are you asking about sexual side effects? Well, in England, they don't ask. In this country, they would ask. In England, they don't ask unless the patient complains. But if you're in a free clinic and they're giving you a drug, I said, this number can't possibly be correct. You didn't ask before, are you having any sexual troubles? And then you only get a report if a patient complains. Well, not too many patients are going to complain in a free clinic. So side effects, particularly with drugs, now the two drugs you mentioned, so the type of examination, even if you take the most superficial thing about sleep on depression, is extraordinarily variable from culture to culture. We have a big problem with this data. I would just add that.
Yeah, well, that's what we're saying, the garbage in, garbage out. It's a limitation, but that's where EHRs and sort of record systems that have prompts in them may help to improve that.
So, so it's very good to emphasize that, really, both of you. So you're limited to what side effects, so we know if you're looking for headache, how often do you encode in the database the fact that the person had a headache unless it's severe or causes a complaint? So a lot of side effects that the average person might care about aren't accurately represented even in any country. And then, as you said, there's differences among countries. And that's why we don't propose to offset randomized trials or prospective studies where you're doing data collect, whether it's randomized or not, prospective data collection where you actually ask the question on purpose, like that's when you really want to know that answer. I'm just talking about comparing what we're doing to other people who are just taking the same retrospective database and not being honest with themselves about how inaccurate it is.
Well, you know, but this is such a potentially powerful approach, but there's several really big challenges, you know, not the least of which is what Ralph was getting at, which is the limitation of the data. I mean, the other is that if you're talking about trying to use studies, there's fewer and fewer comparative effectiveness studies that are being done other than for registration purpose. Those aren't comparative effectiveness. Those are basically registration studies. And so your ability to be able to have enough studies to include in the analysis is diminishing. And PCORI, which was supposed to be funding these things, has been not really lived up to expectations, and its authorization ends in 2019, and under this administration, the likelihood of being renewed is, you know, highly questionable. And then the other thing is, what was the other thing? Oh, so you want to use just observational data in clinical records, okay, which is data that's you know, universally sort of accessible and so forth, and that's wholly dependent on the quality of the information that's in there, which may be dependent on, you know, electronic health records or other ways of getting systematically collected, uniform, and hopefully accurate information into records that could be available for use.
Yeah, I mean, we could try to use the EHR to make the data better by actually asking questions, but as a practicing clinician, do you really want to have the system telling you to put in more and more research data?
Yeah, thank you. That was my third thing, which is that, you know, your initial figures showing the variability in drug use sequences, and how, when it came to antidepressants, it was really embarrassing.
Well,
Doctors don't like to be told what to do. So if you use data to guide practice, which then gets incorporated into algorithms and tiered formularies, that may be good from the standpoint of evidence base and cost efficiency, but there's a big political issue.
Thank you. I'm one of those epidemiologists who do those messy studies. But we have another kind of mess. We have grants to actually look at the prediction of clinical course, familial transmission, and treatment response using MRI, structural, functional, DTI, EEG. There you have, and well, the samples are large, but the amount of data is enormous. And how do you see the use of these methods for these kinds of analysis? We could use some help.
so that's interesting. I mean, you know, it's kind of a two-level problem, which is, I don't know, dimension reduction on the image, large-scale data, then bringing it to something at this level where it's at least feasible now. So, yeah, I don't know, I'd have to look, but there are people working on different automated methods to reduce the number of dimensions so that you have something feasible.
Right now, we're doing the factor analysis on the clinical data.
Mm-hmm.
It doesn't seem to be as big a problem as the other data.
Right. And it's hard, like that example I gave. I mean, that's a form of dimension reduction, right? The study where they found that a penguin look like static noise. You know, I worry about when you do this dimension reduction that if you actually understood what the thing was thinking, you wouldn't be happy with it.
Barbara?
Thank you for a really terrific talk. I found it both exciting and a little depressing as somebody who has done a lot of observational studies. I was wondering a couple things. One is there any possibility of linking your data, which is de-identified, with external data, like death registries, death index? And two, have you begun to think about actually doing, with this massive database that you have, intervention studies, like on infection, control, that kind of thing?
So we're already linking to the death index. The problem with the death index is as states opt out under the new law, that's less and less helpful, but we are using the death index on our database here. So you are getting that information. But we don't get Medicare and Medicaid and map it to our data. It would be nice if we could, but we're not actually going that far. We just do the death index. And then, in Odyssey, what each person does is his own business because they're all their own, it's all their own database. For CPRD, for the UK database, they do a good job of creating a coherent thing. And for Japan, that is their national health, not for Japan, for Taiwan, that is, actually Japan and Taiwan both, that is their national healthcare systems database. So it's as much data as we can get. So we do some linking, but we could do more. But what was the second? Just say the second question again. I forgot now.
Intervention.
So we've just been careful not to go into interventions because we know, look, I presented the talk dramatically on purpose, but we also understand our limitations, and we don't want to go making statements about interventions on observational data for a while until we get a lot of practice doing it on side effects. Side effects are a lot easier than interventions because interventions, there's going to be a bias because people are expecting the intervention to have the effect, the outcome you're looking for. So it's a harder bias, it's a more ingrained bias than just side effects. You weren't expecting the side effects, so there's a little bit less confounding going on. So in a sense, we're taking on the easy problem now on purpose because we think it's a little more trustworthy, or it's a little less dangerous what results we might produce. I don't want to scare people from using a treatment based on something that turns out 5 years from now we realize is faulty reasoning on our part. So we're just being careful. But yes, you can take that database and run a study and ask the question now. But you'll be more subject to confounding, so you have to treat it like you would any other observational result.
Blair, in the back, Rachel.
You know this, you're on our work task force, right? This is one of the strategic themes that our department's looking into, and the question that Harold and Melanie are all raising is, what could we do in this space? Are we ready for this space? And so I had two questions for you, which is one is, and you may have said this at the beginning, I'm sorry, I was a few minutes late. How many patient data points do you need to be able to actually use these methods in a general term? I'm not going to, I imagine for different methods it's different. And then the second one is we view in our department, we have this remarkable opportunity, which is the Office of Mental Health and their systems all across New York State. And we have this fantasy that if we could somehow use this methodology to work with the state, we could, first of all, positively connect Columbia University and the state, which would be really great given some of the tensions that have arisen. But more importantly, could we help the state answer some of their really important health services questions? And that's actually one of the things that the workforce and that we're sort of wondering about could this be possible?
So those two. So first, what size database? My experience, now we have some experience with it, and you need 40 million patient records to answer a lot of questions. 100 million is better, but 40 million is enough. And when you're at 5 million, there's just so many questions, for those data points, Columbia wasn't part of it because their sample size is too small. 5 million patients, but how many actually took the drug you're interested in is the problem. And remember, I already admitted in the beginning that 5 million patient records officially really boils down to 500,000 good records that you can use for research. So you need a pretty big database to do this stuff. It may be a statewide, might be big enough to do something. Indiana's 15 million because it's the whole state. They tend to be able to answer more questions than us at Columbia by itself. So I think that's right around, and that might be, getting closer to the state size. Remember, if it's a mental health database, it's going to be have more mental health drugs in it, and so you don't need quite as big a size. And what was the second question? Sorry.
Well, yeah, I mean, I think you answered it in the same thing, which is that's the idea, which is the Office of Mental Health is all about mental health care. In fact, they
Oh,
are
could
using.
we do it with them? Oh,
and,
so we
and
could,
we
yeah,
are
yeah.
using similar drugs and similar formularies. They're
yeah, yeah.
even on a similar electronic medical record, although I'm told it doesn't collect great data yet. But could we engage the state, and could
Yeah,
this
yeah.
be
So
a?
now I remember the part I wanted to say. So we've managed to engage the South Korean government and some parts of Germany, and who else from a government level? Maybe Taiwan. So we have gotten to the level of the government in some cases to move to this format, to take, not to move to this format, but to make a copy of their database in this format, the OMOP Odyssey format, and have been successful. Of course, New York State is probably tougher than Germany and Hong Kong and South Korea, but probably easier than North Korea, I hope. But we have done this exact pitch to different groups that said, here's why you want to do it, here's why you want to use this database. NCI is about to give us a contract for $100,000 to see if, how well can we do in cancer? Because cancer is another hard one, like
Well, that was my last
psychiatry.
question, which is, well, what would it cost? And it's really only $100,000 to make the database?
Well, once you have the database, converting the database is a couple of programmers, 2 months of effort. So, and then maintaining it is a cost, but it's not millions of dollars. So it's maybe hundreds of thousands of dollars over time, but not millions of dollars.
That's good to know.
David?
So recently, some of us, to get our free excess hospital coverage, had to take a risk management course from MLMIC, which involves 6 hours of droning lawyers that you could not speed up because you had to listen to the tape. And if you got it wrong, they went back and replayed the tape. But anyway, in the midst of all this, what emerged, I was rather surprised, is that they saw the electronic health record as the enemy. It is the minefield of doctors, and it is the major way that people lose out and get sued. And it's not just the porting of previous data, keeping the age the same as you get older. It is also the fact that because of the profusion of boxes to check and everything, there's a fatigue factor, and nobody puts in any fresh, real narrative. And what they want is actually, a narrative in real language about something that is happening that's in real time. So is that necessity a conflict? I mean, it goes back to the old New York State Psychiatric Institute charts, which were read like Henry James. They were long paragraphs. Is that an essential opposition to doing research in psychiatry?
Well, first of all, I think if they enter data that way, it will help research because we'll have real data instead of all this redundant stuff. I mean, a lot of our research is how do you get rid of redundancy in health records. Noemi El-Haddad's work is how to factor out all the repetition. And with natural language processing, we're getting to the point where we can kind of figure out what the person was saying. So the fact that it's narrative doesn't necessarily kill it. It's easier if it's structured, but it doesn't. But we do have a way of doing natural language processing. So I think if we could move, we've been trying to work on getting doctors to produce short, unique notes, but it's hard to get there because it's just easier to cut and paste and throw a bunch of stuff in. I think the user interface will help going forward. So I think, as I tell people, well, it dates me too much, way too much, but there used to be something called the Apple Newton in the 90s, which was the newest mobile computer, and there were all these, Doonesbury had all these jokes about it because you would write something in the Apple Newton and it would say something incomprehensible about it. And then the Palm Pilot showed up and everyone was using it, and that became the iPhone eventually, in effect. So our EHRs are like the Apple Newton right now, where we're sitting there writing stuff in, and what's in there is incomprehensible, referring to your checkboxes and carried forward information. And the research, and none of the companies are successful at this, Epic, Allscripts, Cerner, at producing the thing that, I think there will be an aha moment where oh, if we just did it this way, I could actually enter information that's useful, and I can tell what's new and what's old. They've tried to do it by doing revision marks, like Microsoft Word has a revision mark, so when I copy something forward, I know what I did versus what the previous did, but it's just a big mess. So someone will invent something better. But part of it is the policy that you get billed for it, and that's also limiting what we can do.
Well, listen, this is the fascinating beginning of what I hope will be sort of a growing discipline and collaboration for us to pursue with you. So thank you for coming, and to be continued.
All right, thank you.